Thank you, Meredith, for that characteristically stunning introduction. I'm afraid it's all downhill from here. It's such a pleasure to speak with you all today. Before I begin, I'd like to express my appreciation to the Radcliffe Institute for hosting me this year, to the National Science Foundation for supporting this research, and of course to my undergraduate research team, without whom this research would not be possible. To give you a little bit of background, I'm a medical sociologist and a socio-legal scholar, so I do research at the intersection of healthcare and law. And I'm particularly interested in the cultural context of professional decision-making. So when providers are making decisions about prescribing or dispensing medications, to what extent are they influenced by their organizational policy, by their political environment, and by their legal environment? And relatedly, I'm interested in how the decisions that they make affect inequality in healthcare access and also exposure to the criminal justice system. So my current project uses the opioid crisis as a case for understanding how healthcare providers make decisions about politically controversial drugs and what the impact looks like on patient care. Last month, while facing 2,600 state and federal lawsuits, Purdue Pharma, the maker of OxyContin, declared bankruptcy. For many families and activists, this was cause for celebration. The enemy had been vanquished, the dragon had been slain, and the people were finally liberated from 20 years of pain and loss. But this victory over Purdue is only truly celebratory if we imagine that the driver of the contemporary US opioid crisis can be reduced to a single causal factor: a bad drug company selling addictive wares to an unsuspecting public. A company that used shoddy science to convince regulators to give them a market advantage that they then used to hoodwink physicians into carelessly prescribing their drugs, leaving a trail of destroyed lives in their wake. Nefarious people who sold a drug so powerful and so addictive that people were helpless to escape its grasp. This kind of fairy tale, with easy-to-identify villains and victims, resonates powerfully with Americans who live in a society that privileges singular answers over complex ones and that prefers to attribute social ills to bad actors instead of bad infrastructures. I came here today to share a different kind of story, a story that accounts for the nuanced and varied factors that have contributed to the opioid crisis. This story is far from a fairy tale. For many, it is a living nightmare, full of impossible choices, one in which heroes die and in which villains, who are all the more powerful for being nameless and faceless, prevail. A story of a society in which the lines between illness and criminality are blurred, where the punishers do the treating and the healers do the punishing. A story in which the color of a person's skin and the substance that they use affect whether they receive punishment, care, or punishment disguised as care. A story in which suffering people are denied relief under the auspices of protection and support. A chilling story, yes, but one necessary to unravel the tidy image knitted together by simplistic threads of blame so that we can finally understand the deep interrelated complexities of social problems and arrive at policy solutions that honor their subtleties. The overdose crisis is both a devastating tragedy for those whose loved ones are caught in its grip and a constructed social problem, one shaped by institutional power dynamics that affect how we define, elaborate, and respond to this issue. In other words, the so-called opioid crisis and our approaches to confronting it are distinctly cultural phenomena. Contemporary approaches to the opioid crisis are dominated by two fields: healthcare and criminal justice, that bring very different worldviews, tactics, and resources to bear, and that are independently inadequate to tackle a problem of this magnitude. My research examines how these disparate fields manage the same social problem, the implications for how these fields operate, so how might these fields look different as a result of dealing with this social problem, and implications for patient care and exposure to the criminal justice system. I'll begin by discussing the origins of the US opioid crisis. Then I will share original research findings on how technological solutions are impacting the fields of healthcare and criminal justice and shaping inequality in healthcare access and exposure to punishment. I'll conclude with a set of policy recommendations designed to intervene meaningfully into the crisis. Our story begins with a series of troubling trends. The number of drug overdose deaths has risen precipitously over the past 20 years. In 1999, there were around 17,000 drug overdose deaths. By 2017, that number had quadrupled to 70,000, making drug overdose the leading cause of accidental death in the United States. Around 17,000 overdose deaths, or 24,000 in 2017, involved a prescription opioid, things like oxycodone, hydrocodone, and codeine. Physicians were complicit in flooding drug markets with prescription opioids. Physicians prescribed about 3 times more opioids in 2017 than they did in 1999. These are the facts. But there are 3 major problems with how these facts have been presented in the public discourse. One problem is that despite receiving a hefty share of the blame for overdose deaths, this iatrogenic or physician-caused pathway is only part of the story. In 2017, twice as many overdose deaths were attributed to heroin, synthetic fentanyl, and other synthetic opioids as compared to prescription opioids, which represents a 16-fold increase from 1999. This suggests that there exists a second non-medical pathway to overdose death that cannot be explained exclusively by Purdue's unethical business practices. A second problem is that what many leaders consider a 20-year problem is in fact a 120-year problem, an extensive duration during which the policy pendulum has swung repeatedly between punitive and rehabilitative approaches to opioid addiction. And this swing of the pendulum is related to broader trends in racialized drug policy, whether the focus is on Chinese laborers and opium, Mexican migrant workers and marijuana, or African Americans and crack cocaine. We see time and again that the criminalization of drugs is a mechanism for criminalizing people, particularly those people who belong to poor minority groups. Throughout the last century, the lens through which addiction has been refracted, whether one of badness or one of sickness, has been formed through racialized and class notions of moral worth. A third problem is that the language and imagery used to frame this social problem warrant skepticism. What's been called an opioid crisis, or even an opioid epidemic, is in fact the confluence of 2 crises, an overdose crisis and a pain crisis, at the intersection of which lie problems of pain, addiction, and diversion. And by diversion, I'm talking about the sale of prescription drugs through illicit markets. Pain is rampant in the United States. In 2011, the Institute of Medicine reported that at least 116 million Americans suffered from chronic pain. But determining whose pain is legitimate and which patients deserve resources has been a decades-long political enterprise. In the 1960s, anti-opioid sentiments were so prevalent and the policy pendulum had swung so far towards punishment that cancer patients were dying in pain, while the drugs that would have relieved their suffering were available but inaccessible. These inhumane practices mobilized the British hospice movement in the late 1960s and the US pain management movement a decade later, both movements pushing the pendulum towards treatment. When OxyContin was released in 1996, it was a godsend for chronic pain patients. Its 12-hour slow-release formula enabled them to sleep through the night, and it carried much lower risks of organ damage compared to its competitors. However, Purdue Pharma gained a market advantage by convincing the Food and Drug Administration to allow them to label OxyContin as less addictive than other opioids, which we now know is not true. They also tapped physician thought leaders to market the drug, and they targeted physicians who are known to be especially heavy opioid prescribers. Meanwhile, the Joint Commission on Accreditation of Healthcare Organizations, this is the organization that accredits hospitals, labeled pain the 5th vital sign and began using patient satisfaction surveys about pain treatment as a factor in hospitals' reimbursement rates. Collectively, These business practices, social movement efforts, and regulatory changes gave way to a liberal prescribing moment that catalyzed the tsunami of opioids that began to flood illicit markets in the 1990s. Today, the heyday of opioid prescribing is over, and the pendulum has once again swung back towards punishment, leaving providers hyper-aware of their legal terrain. Legally, physicians are beholden to the 1970 Controlled Substances Act that requires physicians to prescribe in good faith, meaning for a legitimate medical purpose for an established patient, while it also assigns pharmacists what's called a corresponding responsibility to avoid dispensing drugs for non-medical purposes. The questions physicians and pharmacists face, to prescribe or not to prescribe, to dispense or not to dispense, occur within a medical context in which pain and addiction are incompletely medicalized and options for treatment are few. Both conditions are nominally framed as illnesses, but their most effective treatments are rarely covered by insurance, and most physicians lack the knowledge and resources to effectively treat them. For addiction, criminal justice solutions have entered the breach and have taken three forms. First, criminal justice agents are increasingly performing healthcare work. Police are administering naloxone, a drug overdose antidote, and they're participating in programs like PARI, which stands for Police Assisted Recovery Initiative, through which people surrender their drugs to the police as a first step to receiving treatment services. Second, criminal justice spaces, like prisons and jails, have become de facto treatment spaces because many policymakers buy into myths about addiction, such as the idea that only by hitting rock bottom can people turn their lives around, as if addiction were a choice. So incarceration ends up standing in for other, more effective forms of treatment. Third, and this is the one I'm going to focus on, criminal justice technologies are being implemented in healthcare spaces. Notably, 49 states, all but Missouri, have adopted statewide prescription drug monitoring programs, or PDMPs, that track controlled substance dispensation in the state. What is a PDMP, you ask? PDMPs, prescription drug monitoring programs, contain aggregated pharmacy dispensing data that's entered at the point of care. So if you go to a pharmacy and you have a prescription for oxycodone, the pharmacist dispenses that, but then they send a record of that dispensation along with all of the other controlled substances that they've dispensed either that day or that week to a company that partners with the state to put all of that information into the prescription drug monitoring program. So the PDMP gets information about all the controlled substances dispensed throughout the state, and then it feeds that information back to physicians and pharmacists who can use that information to make decisions about whether or not to dispense to a patient. So here is an example of a traditional PDMP report. It's basically an Excel spreadsheet, and it has information about a patient's drug history. So the kind of drug they've taken, the amount, where they've gotten it, which doctors they've gone to, which pharmacies they've gone to, et cetera. So I want you to think for a moment, if based on these data, you would choose to prescribe an opioid to a patient. Now, I'm guessing that many of you have no idea. Partly because you're not a doctor, or you're not that kind of doctor, and partly because this information is very difficult to read, and not just because it's blurry. Processing these data requires a lot of cognitive work that takes far more than the 20 minutes that physicians usually get to spend with their patients. Well, I have great news for you. The PDMP has been evolving. It's gone from PDMP 1.0, this wholly unreadable Excel spreadsheet, to PDMP 2.0, which does more analysis for you. It shows you scores for narcotics and sedatives and stimulants, and sometimes it even contains an overdose risk score. And sometimes it's in color, so like you can see that they're in the red. And then you know what you're supposed to do. All right, if this looks familiar to you, it might be because these exact same kinds of algorithms are being used in the criminal justice system to assess the risk that incarcerated people, if released, will engage in public harm. In fact, the same company that runs 45 out of the 49 US PDMPs also offers a suite of criminal justice surveillance tools, including this one, Risk Intelligence. This is designed to help employers avoid hiring people with criminal justice convictions. So much for banning the box. We're not done yet. We're starting to see prototypes of PDMP 3.0 that integrates information like arrest records into the PDMP so that before prescribing opioids, providers can see if a patient has been arrested for a drug crime. But wait, there's more. PDMPs are not used exclusively in the healthcare system. They're also used by law enforcement to track both patients and providers. In addition to seeing the same kinds of data that providers can see, law enforcement can also see information about prescribing and dispensing. So they can create charts and graphs that look like this, and they can identify, well, who is the highest prescriber in the state of Mississippi, or who is the highest dispenser in the state of California. PDMPs, then, are two-tiered big data surveillance systems. They constitute a critical point of intersection between the fields of healthcare and criminal justice because workers in each field use the database in their daily work, albeit to different ends. But what does the use of shared surveillance technology mean for professional work and for patients' access to care? I began exploring this question when I first heard about PDMPs in 2011. I had just completed the project that Meredith spoke about, where I interviewed 100 pharmacists throughout the US about how they made decisions about dispensing opioids. And I should note for a minute that pharmacists are far more important than most people think. I think most people think that pharmacists do nothing more than put pills from big bottles into little bottles. And they also think that pharmacists do exactly what the physician tells them to do. And I am here to tell you that that is not the case. Pharmacists practice under their own professional license, and they get to make decisions about the care that they provide, although many of their decisions are refusal. I mean, they can't give you something different than what the doctor prescribed, but they can refuse to give you what the doctor prescribed. So in our highly pharmaceuticalized society, where there's a drug for everything that ails you, pharmacists serve as gatekeepers to prescription drugs, which gives them significant power. When I asked pharmacists how they made decisions about whether to dispense opioids, many of them mentioned a gut feeling that they took as indicators that something wasn't right. Of course, my sociological imagination led me to wonder what was behind those gut feelings. Were pharmacists just really good at differentiating between pain, addiction, and diversion? Or were they really reading race, class, and gender and making decisions based on cultural stereotypes? Since I already had data on how pharmacists made decisions before the PDMP, I decided to re-interview a subset of those pharmacists and also expand the scope of the project to include physicians and law enforcement. So that resulted in 182 interviews that I conducted between 2009 and 2019 with healthcare providers and enforcement agents, primarily in 3 states, California, Florida, and Missouri. So I'm going to share with you data from this project today. What I found was surprising. Not only has PDMP use changed pharmacists' behavior, but the use of this technology is blurring boundaries between healthcare and criminal justice. Both fields are changing, but they're changing in different and interrelated ways. I'll discuss what these changes look like by highlighting 4 interrelated processes: technological expansion, technological encroachment, transformation, and channeling. So let's begin with technological expansion. To combat the opioid crisis, enforcement agents have developed more expansive toolkits for identifying and punishing crime. Essentially, they've added new dimensions to routine work without fundamentally changing the work itself. There's a steep learning curve for both investigators and prosecutors who are doing cases against providers. PDMPs serve as tools of efficiency. They help enforcement agents identify problematic behaviors and decide which people to target. Just to give you a sense of what the enforcement environment looks like, providers can be investigated by a wide range of enforcement agencies. These include, but are not limited to, the DEA. The DEA is a hybrid organization, so they can go after providers criminally with the goal of putting them in jail. They can also go after them administratively, and when they do that, they're going after the DEA registration number, which is what allows a provider to either prescribe or dispense controlled substances. A second type of organization is a professional board, so the Board of Medicine or the Board of Pharmacy. These are organizations that are responsible for licensing professionals, and so they can go after them administratively. They can revoke or suspend or discipline their license. And then third, you have organizations that can go after providers for fraud. Those are organizations like Health and Human Services Office of the Inspector General at the federal level, or Medicaid fraud control units at the state level. And so they can go after these providers criminally, or they can seek to limit their national provider identifier, which is what allows them to bill government insurance. Any one of these cases can be career-ending, and they often have a domino effect. So if you lose your medical license, you also lose your DEA registration. But if you lose your DEA registration, there's a good chance you're also going to lose your license. And nobody is going to hire you if you can't prescribe controlled substances, if you can't bill government insurance. And so any of these is really troubling. Providers then are navigating thorny legal territory when making decisions about opioid prescribing and dispensing. Now, this requires some changes for the investigators too. Many investigators who are used to doing illicit drug cases suddenly find themselves doing prescription drug cases. These aren't about illicit drugs. They're about prescription drugs being used illicitly. So investigators have to develop new strategies. It's not enough just to see that somebody has OxyContin. You have to figure out why they're using it. It's not enough to say that a physician is selling OxyContin. You've got to figure out why it's being used. Eric, a police officer in Southern California, describes how he susses out this information when he finds prescription drugs during a traffic stop. He says, you want to nail them down and ask them, hey, what drug is this? If they tell you something bogus, be like, okay, because their defense is going to be, it was prescribed to me legally by my doctor. You want to ask, well, what's your doctor's name? They're going to make it up. Oh, it's Dr. Smith. Well, what were Dr. Smith's directions? They're going to say, I'm supposed to take it 5 times a day. Well, again, you're locking them into a statement. They're going to have to show you in court that Dr. Smith prescribed them Vicodin where they're supposed to take it 5 times a day. And the jury is going to see that, wow, he's lying, he's lying, he's lying. People who get medications for chronic pain typically know their doctor, they know their pharmacy, they know the instructions for how they're supposed to be taking these medications. By contrast, people who have substance use disorders or who are diverting drugs often get drugs from multiple physicians and pharmacies, so they don't know which bottle the enforcement agent has in his hand, and that makes it very hard for them to defend themselves. Cases against providers are similarly complicated because investigators can't just show that the provider sold the drug. They have to show that providers are knowingly furnishing drugs with no legitimate medical purpose. So how can investigators show that providers are behaving inappropriately? Provider cases typically begin in a reactive way. In response to a report from either an anonymous tip line, other providers, neighbors, family members, or other agencies. Before the PDMP, law enforcement might receive a tip. And so then they would look at all of the pharmacies in the area, surrounding a particular physician's office, and then they would go from pharmacy to pharmacy to pharmacy, gathering all of the prescriptions that this physician had written. Now, you can imagine this is a very time-intensive strategy, and it yields incomplete results. The PDMP makes this a whole lot easier. Now investigators can run analyses on patient data and look for provider outliers. Mike, who's a federal agent in Missouri, describes his strategy. He says, I'll just start looking through that Excel spreadsheet, which is the PDMP, and ordering it by different criteria. Okay, well, how many people with the same address are getting narcotics prescriptions from the same practitioner? How many individuals are getting just an obscene amount of oxycodone? Once they identify problematic trends, they use the PDMP report like a treasure map to get the actual prescriptions from the pharmacies. Like investigators, prosecutors experience a steep learning curve when they begin doing doctor cases. As a result, many prosecutors are hesitant to take on these cases. They're long, they're resource intensive, and they're politically risky. For prosecutors who do take on these cases, PDMPs are useful because they help them to identify potential witnesses in provider cases. Jack, a prosecutor in California who had done multiple investigations of physicians, describes how he's used the PDMP. He says, we were looking for potential witnesses who could explain to us what went on in this physician's business. So I looked at Cures. Cures is California's PDMP. And I'm like, I'm going to find every person that was going to her for a regular period of time and then dropped off. Why? because either they died or they went to rehab, because you don't get 120 Vicodin for 3 years and then suddenly just stop. So I could have my investigating officer run the names and say, hey, go out and pound the pavement and see if these people are willing to talk. And I think we got 6 or 7 former patients of hers who had gone into rehab and who are now willing to be witnesses. Technological expansion, then, makes it easier for enforcement agents to perform effectively and efficiently. And it facilitates a second process that I call technological encroachment. Technological encroachment is the process by which big data surveillance technology transports logics or ideals from one field into another. Technological encroachment has occurred in response to the overdose crisis as hospitals, clinics, and pharmacies have implemented PDMPs and have begun requiring healthcare providers to use them. This is also a requirement in some states at this point as well. But this technology does more than inform healthcare providers about their patients' drug acquisition behaviors. It carries with it punitive logics that are typically associated with criminal justice rather than healthcare. A helpful way to think about technological encroachment is to envision the PDMP as a Trojan horse. You have 2 fields, criminal justice, where the technology is constructed, and healthcare, where the technology is implemented. Going with this metaphor, the horse is the technology, and the Greeks are the logic of criminal justice that are embedded within the technology. When the Trojans, healthcare leaders, wheel this gigantic Trojan horse within their walls, they don't realize that this beautiful symbol of victory is accompanied by Greeks who want to kill them. Now, this is where the metaphor breaks down a bit. The logics do not leap out like Greek soldiers, but rather reveal themselves slowly over time through routine use of this new technology. Technological encroachment, then, is a hegemonic mechanism by which criminal justice achieves dominance over healthcare, because criminal justice logics become taken for granted elements of healthcare practice. This results in a third process, the transformation of the healthcare field. Pharmacy and medicine respond to technological encroachment by reorienting themselves around criminal justice logics of surveillance and punishment. Workers in both fields begin to behave like hybrid medico-legal agents as they engage in medical and legal gatekeeping. This transformation is evident in how providers shift their roles, routines, and relationships, all of which are now suffused with criminal justice logics. Providers use the PDMP to assess whether the patient is struggling with a substance use disorder, is in pain, or is diverting drugs. Physicians and pharmacists are torn between 2 competing roles, that of medical gatekeeper, who is focused on an individual patient's health, and that of legal gatekeeper, who's focused on policing the patient in the name of public safety. PDMPs help providers to adopt the trappings of legal gatekeeping, something that pharmacists were far more comfortable with starting in 2012, when PDMPs were widely available, than in 2009 when they were not. When I interviewed Sarah, a chain pharmacist in California, she stated unequivocally, "I am not in the police business. That's the least fun part of my job, is feeling like you're a police." Like many pharmacists at that time, Sarah clearly defined policing patients as outside of her professional purview. By 2012, pharmacists had grown far more accepting of the legal gatekeeping role. In fact, many of them considered it fundamental to their professional practice. Kevin, an independent pharmacist in South Florida, explained, "I think it's an enforcement tool to find out a patient's history, something I never would have had access to if I couldn't see all the information on there. Most patients aren't going to tell you. They're not going to give you that information." So the technology helps him to engage in legal gatekeeping by providing him with access to data that he would not otherwise have. Medicine has undergone a similar shift, but physicians often reframe surveillance as part of treatment rather than seeing it as part of enforcement. When I asked Blake, a pain management physician in Kansas City, if he considered PDMP's enforcement tools, he replied, "I'm going to call it monitoring and not prescribing to anyone who's abusing or misusing the medications that I prescribe. If it were policing, I would have a punishment rather than a withholding. Withholding a medication is not putting somebody in jail. It's not fining them. It's withholding a benefit that they may have received if they had followed the prescribed regimen. So I'm not policing, I'm monitoring." Physicians like Blake resist the idea that they're policing patients and instead reframe their surveillance actions to make them fit within their schemas of what doctoring should look like. As providers embrace new roles, PDMPs also help them to incorporate surveillance into their daily routines. Pharmacists use red flags, things like appearance and behavior, to determine whether or not they're going to dispense opioids. When they identify red flags, they often opt out of dispensing. However, when they have the PDMP, it changes how they say no to the patient. Prior to the PDMP, pharmacists took themselves out of the equation by saying that the drug was out of stock. From the patient's perspective, an out-of-stock drug is one that a pharmacist can't provide, not one that they won't. Pharmacists are far more assertive when armed with a PDMP report. Laura, a California chain pharmacist who I interviewed in 2013, explains how she uses the PDMP data to confront the patient. Before it was more like, I'm not comfortable. Well, why aren't you comfortable? And now we're like, because you went to these 2 other doctors, you filled it at this independent pharmacy, you filled it at this other retail pharmacy, and then I'll be like, within 30 days, you filled 480 tablets. That's a little too much. And now they're like, okay. However, sharing PDMP information does more than simply reflect patients' drug acquisition patterns back to them. It also signals to the patient that the pharmacist is monitoring them, that they know where they're getting drugs and how much, and it can be a means of deterring patients who are getting drugs for non-medical purposes. Compared to pharmacists, whose key enforcement tool is the PDMP, physicians have options. PDMPs are part of an arsenal of enforcement tools, including pain contracts, urine drug screens, and random pill counts. Pain contracts typically confine patients to a single physician and a single pharmacy and require patients to use only those drugs that the doctor has prescribed. To ensure that patients are adhering to the pain contract, physicians use PDMP reports along with urine drug screens to corroborate or contradict patients' self-reported drug use. Josh, a physician and a leader in a state medical association, explains how he uses the PDMP in conjunction with other tools. Okay, so I've given you 5 prescriptions for opioids. Time to check the PDMP again. Oh, this is interesting. You filled opioids, but we did a urine test, and there are no opioids in your system. Or you can say, I gave you these prescriptions, which should be enough for the pain that we've discussed, yet you're in here after having gone to 3 other physicians. So from a practice standpoint, it can provide useful information, particularly if the patient isn't being honest. Do you see how suspicious these providers are of their patients? They're thinking, this patient's not giving me the information, this patient is not being honest with me. Think about what that does to the fiduciary relationship. Surveillance becomes part of healthcare providers' routines as they embrace legal gatekeeping roles and employ technology that renders surveillance easy and automatic. PDMPs also help healthcare providers to reimagine and reconstitute relationships with one another and with law enforcement. Physicians and pharmacists are positioned in a hierarchy in which physicians exercise significantly more formal power. However, the Controlled Substances Act requires pharmacists to make sure that physicians are prescribing appropriately. This can be a tricky obligation to fulfill because pharmacists don't normally have access to information like the diagnosis or the treatment. Prior to the PDMP, pharmacists often encountered resistance when they called physicians to discuss a prescription. Jim, a chain pharmacist in Northern California, sighs as he tells me, whenever I have to call to talk to a doctor about a medication, they generally don't want to listen. Sometimes they say, I'm the doctor, you're the pharmacist, you do whatever I say. Organizational policies requiring PDMP use help pharmacists to counteract resistance when calling physicians. Tracy describes how this has changed her interactions. When my chain implemented a checklist, physicians weren't happy. They were like, what is this? I've never seen this. Why are you asking me so many questions? And basically, we're just like, we needed to make sure the patients are not legitimate, we don't use that word, but under the correct care. We just need everything to be documented now. So now they're kind of used to it, but yeah, they were pretty hostile. Pharmacists circumvent traditional power dynamics by using their store policy and now state law to justify their need for patient information, while at the same time sending the physician subtle messages that they're being monitored and that their prescribing practices might be a problem. Beyond resituating relationships between healthcare providers, PDMPs also help create closer relationships between providers and enforcement agents. PDMPs help to form an alliance between pharmacists and enforcement agents. Prior to the PDMP, pharmacists did not consider drug monitoring part of their job. Recall Sarah, who stipulated that she was not in the police business. Even when pharmacists did try to ally with law enforcement, they often had little to go on, a gut feeling or a red flag or two, not really enough to motivate law enforcement to take action. With the advent of the PDMP, however, pharmacists conceive of their relationship with law enforcement much more positively. For example, Daryl, a California chain pharmacist, claims, "One of our primary functions is we're the drug controllers. So in truth, we're partners with the DEA because their whole job is to control all of the drugs, the legal and the non." I don't know about you, for me it was very surprising to hear pharmacists thinking about themselves as allies with traditional enforcement agents like the DEA. Law enforcement agents report similarly positive relationships with pharmacists. In fact, they consider pharmacists some of their best sources for initiating investigations. Joe, a California sheriff's deputy, told me, "We usually get our tips from pharmacies when it comes to a patient-doctor shopping. We arrested a lady recently who went to 126 physicians in 1 year and got over 10,000 allotted pills. The pharmacist said, 'Hey, I ran a cures report. When she came to fill the script, it's out of control. You're going to need to look at her.' So we did, and we arrested her for doctor shopping." This suggests that pharmacists are not only gatekeepers to healthcare resources, but they're also gatekeepers to the criminal justice system, responsible for moving patients along the treatment to prison pipeline. Physicians are a different story. Even though physicians have readily embraced enforcement tools and logics, they have not equally embraced enforcement agents. Physicians are aware of potential enforcement action against them, and they conduct their practices accordingly. However, physicians are far less likely to report proactively contacting law enforcement about their patients. When Blake described a patient with a positive drug screen, I asked why he didn't reach out to the police or to the DEA. He responded, "If I see a positive drug screen, I think that's a medical issue. That's between a doctor and their patient. And I don't think it's even legal for me to call law enforcement to say, 'Hey, this patient is doing this drug.' I'm not calling law enforcement. I'm just no longer prescribing if I suspect diversion." Healthcare providers' adoption of enforcement activities paired with fortified relationships between pharmacists and enforcement agents raise questions about what these changes mean for healthcare provision and healthcare access. To understand these implications, we turn to a fourth process, channeling. Healthcare providers constantly encounter patients struggling with pain and substance use disorders, yet they have received new tools to surveil and punish, but not to treat those under their care. Healthcare providers respond to this treatment-poor, enforcement-rich environment by using the PDMP to channel patients out of the healthcare system and into the criminal justice system. In doing so, they expose patients to cumulative inequality that builds up over time within and across the fields of healthcare and criminal justice. There are two types of channeling, direct and indirect. Direct channeling is when healthcare providers contact law enforcement about a patient. It's relatively rare. Far more common is indirect channeling. When providers refuse to prescribe or dispense regulated prescription drugs, they expose patients who are physically dependent on those drugs to dangerous, unregulated, illicit markets that carry a far higher likelihood of injury and overdose. Providers are not exclusively responsible for illicit drug use. I'm certainly not saying that. But by pushing patients out of the healthcare system, they simultaneously nudge them towards riskier markets while sacrificing an opportunity to help a sick patient. PDMPs have been touted as healthcare tools, ways for providers to identify and correct risky patient behavior, but they're rarely used that way in practice. Instead, providers generally use PDMPs to justify refusing to provide care. Pharmacists use PDMPs to indirectly channel patients out of the healthcare system and into criminal justice. Prior to the PDMP, pharmacists made decisions based on their interpretations of patients' behavior and social cues. Today, pharmacists trust PDMPs to accurately depict patient behavior, so they use the PDMP data to refuse to dispense. Physicians engage in channeling by setting restrictive standards for pain patients under their care. The legalistic pain contracts that physicians require pain patients to sign subject them to regular drug screening. If prescribed drugs fail to show up in the patient's urine, or if illicit drugs appear, the physician has reasonable cause for dismissing that patient from the practice. Colin, a primary care physician in Missouri, explains how he addresses PDMP data with patients. He says, I would say, look, there's pretty good evidence that you're seeing a lot of other doctors, and because of that, you're in violation of the contract we have with you. We just have to investigate a little bit, but if they're truly shopping around, we say, look, I don't want any part of this. I'll see you for your hypertension, but I'm not gonna give you opioids anymore. Although physicians do not always dismiss patients after a single infraction, this possibility looms large for patients under opioid care. Being dismissed from a physician's practice can have dire consequences. Patients on high opioid doses struggle to find new providers due to changes in the pain management landscape. Today's physicians who receive training in the shadow of the opioid crisis typically believe that opioids are dangerous and that they should only be used as drugs of a last resort. These physicians hesitate to take so-called legacy patients, patients who have been on high-dose opioids for a prolonged period of time, leaving these patients struggling to find physicians who will treat them without forcing them to taper their meds. For patients, tapering can mean the difference between engaging in daily activities and being immobilized by pain. Instead of channeling patients suffering from pain and/or addiction into the healthcare system, which providers are ill-equipped to do, providers relinquish them to unregulated markets, thereby increasing the likelihood of patient harm and entanglement with the criminal justice system. This results in an exacerbated form of cumulative inequality that carries across healthcare and criminal justice and has different consequences depending on the patient's social position. It is well documented that race, class, and gender discrimination limits access to pain medication and addiction treatment, and these same forms of discrimination shape the likelihood of arrest for drug crimes, acceptance into diversionary programs like drug courts, length of sentencing, and post-incarceration life chances. There are significant racial and socioeconomic factors undergirding the opioid crisis, and poor people and people of color are taking the brunt of providers' actions. In many ways, the opioid crisis has turned professional worlds upside down, which raises questions about who we want our healthcare providers to be. If they attempt to embody both punitive and healing roles, how might their enforcement requirements impede their fiduciary obligations to patients? The four processes I've described here, technological expansion, technological encroachment, transformation, and channeling, are part of the mechanism by which social problems transform social fields and by which the opioid crisis is blurring the boundaries between healthcare and criminal justice. Surveillance technology exacerbates the criminalization process. As our world becomes increasingly digitized and as big data surveillance technologies become taken for granted aspects of lived experience, surveillance facilitates enormous potential for social control and inequality. Sociologist Sarah Brain has demonstrated that the growing links between criminal justice and other social fields results in system avoidance. That is, they've motivated people to avoid social spaces like hospitals, libraries, and welfare offices out of fear of arrest. This has devastating implications for the urban poor who already suffer from severe social inequities. So where do we go from here? To find meaningful and effective solutions, we need to begin by reframing the problem. Our leaders are treating the opioid crisis as a medical problem and creating policy solutions in the healthcare arena when the actual problem extends far beyond the bounds of healthcare and implicates a wide variety of social fields. Only when we account for the nuances of drug use and the contours of drug criminalization will we be able to create policies geared towards meaningful and sustainable solutions. To that end, I will conclude with some concrete actions we can take. First, we should set boundaries around how PDMP data is used. There are a wide variety of stakeholders who see the potential utility and profitability of PDMP data. Once created, a database like this takes on a life of its own. So we need to put safeguards in place to protect patient privacy and limit the commodification of these systems. Second, we need to equip healthcare providers with harm reduction tools. If a person is drowning and somebody throws them a life preserver, they don't stop to think, well, who threw that? Where did that life preserver come from? Or is this really the right life preserver? Or, maybe I'm gonna wait for a better life preserver to come along before they cling to it for dear life. Our healthcare providers are drowning in the daily challenges of the opioid crisis, and the only life preserver that we have thrown them is a criminal justice surveillance tool. We can do better than that. We need to expand our mental health and substance use treatment infrastructures by training physicians how to treat pain and substance use disorders and expanding Medicare and Medicaid. We can make better use of pharmacists, our most available but most underutilized healthcare providers, by encouraging them to take on the mantle of harm reduction and equipping them with the resources to treat pain and addiction. Third, we need to upend the practice of treating through crime by recentering healthcare and public health as the pathways by which individuals struggling with substance use disorder can get treatment. We need to establish direct mechanisms of care provision that do not require police involvement. For example, imagine a 911 for mental and public health emergencies staffed by psychologists and social workers that is incorporated into city and state budgets and is not contingent upon grant funding. They're already doing things like this in Sweden. Finally, we need to target the psychosocial factors that cause drug crises. Medicine and criminal justice are vast fields, but they offer blunt tools for addressing social problems like homelessness, unemployment and underemployment, educational inequality, domestic violence, food insecurity, and hyper-surveillance that give rise to drug crises. Only by expanding our social safety net and ensuring care for all people can we hope to disrupt the cycle of overdose and death. Law has a tendency to lag behind social problems. Today's lawmakers are so busy litigating yesterday's problems that they fail to plan for the problems that lie ahead. And law moves slowly at a glacial pace, while social problems are adept and adaptable, changing quickly and without warning. In a 20-year period, the United States went from 17,000 overdose deaths to over 70,000. In 4 short years, the driver of these deaths went from prescription drugs to heroin and synthetic fentanyl. Meanwhile, the victory that we're celebrating is over the pharmaceutical industry. We've entered a new chapter in our story. Purdue may have been vanquished, but the social conditions, economic incentives, and regulatory holes that facilitated its rise to power persist. Today's opioid crisis is little more than the latest iteration in a cycle of moralized, racialized drug panics that have occurred over the past century. Our myopic policy approaches to drug crises make it impossible to escape these cycles because funding is tied to specific drugs and to narrowly defined outcomes. At the federal level, there is an enormous wave of funding to address the opioid crisis, but our crisis is not about a class of drugs. It's about tears in our social fabric that leave gaping holes in resources for marginalized communities, and about the failure to address the psychosocial underpinnings and rampant criminalization of drug use. Instead of trying to eradicate opioids, we must find a way to dramatically reduce human suffering. Only then will we truly break free.